So my name is Nicholas Short from the University of Texas MD Anderson Cancer Center. And this year we're presenting our data on the combination of blinatumomab and ponatinib in patients with Philadelphia chromosome positive ALL. This is a patient population that's historically been treated with intensive chemotherapy plus a BCR-ABL TKI. We've done some studies looking at ponatinib, which is a more potent TKI in the setting, and there's also been a recent study, the DIALBA study, that's evaluated a chemotherapy-free combination of dasatinib with blinatumomab in the frontline setting. So we wanted to evaluate this more potent TKI ponatinib in combination with blinatumomab to see if we can have an effective chemotherapy-free regimen, and also potentially one that decreases the need for transplant in first remission. So in this study, we evaluated two main cohorts of patients: those with newly diagnosed Ph-positive ALL, those with relapsed refractory Ph-positive ALL. Patients received 5 cycles of blinatumomab at standard doses in combination with ponatinib, 30 milligrams daily. The ponatinib is then decreased to 15 milligrams daily once patients achieve a complete molecular response. And then we like to continue the ponatinib for at least 5 years thereafter. So far, we've treated 35 patients, 20 patients in the frontline setting, 10 patients with relapsed refractory Ph-positive ALL, and 5 with CML and lymphoid blast phase, which is another small subgroup of the study. Overall, all but 1 patient responded. So this is a 96% response rate. The complete molecular response rate overall was 79%. Among patients who were newly diagnosed, the response rate was 100%. So all patients responded, and 85% achieved a complete molecular response. In the relapsed refractory cohort, the response rate was 89%, and then 88% of those patients achieved a complete molecular response. So at the last follow-up in the frontline cohort, the 2-year overall survival and event-free survival rates were 93%. Of note, no patients in the frontline cohort have relapsed, and importantly, none have undergone transplant in first remission. In the relapsed refractory cohort, the 2-year overall survival rate is 53%, and the 2-year event-free survival rate is 41%. Overall, the toxicity of these drugs has been as expected, and there wasn't any signal for any added toxicity when these are combined. So overall, we're very encouraged by these data, particularly in the frontline setting, where we're seeing extremely high response rate with all patients responding, very high deep molecular response rate with an 85% complete molecular response rate. And importantly, no patients having relapsed at last follow-up, despite none of them undergoing transplant in first remission. So we believe that this may be we believe this is an effective chemotherapy-free and potentially transplant-sparing regimen, particularly in the frontline setting. This study continues to accrue patients, and I think for future considerations, this study could be expanded, or similar strategies, also to include younger patients and even pediatric population. When we first started this study, there was some apprehension about moving to an entirely chemotherapy-free regimen for younger adults, so let's say patients less than 60 years of age, who we've always historically given intensive chemotherapy to. However, the data to date have been very encouraging, and I think provide a platform and kind of rationale for potentially evaluating these chemotherapy-free regimens, even in younger and pediatric populations. Thank you very much for your time.